All right. Hello, everyone. Welcome to the Cardiogenic Shock Virtual Grand Rounds. My name is Shayna Costello. I'm the Senior Manager for the American Heart Association's Cardiogenic Shock Registry. And thank you so much for being here. And if we can go just to that next slide, please. All right, just a couple of quick housekeeping reminders before we begin. Just to note that this meeting is being recorded and the recording will be archived on our registry's website. So we have that linked on the slide, but it'll also be listed on the end. Also, this is a large group, so if you could please remain on mute unless you're asking a question. We do recommend putting your questions in the chat. Our team will be monitoring that, and then they can be addressed during the designated time for Q&A. So next slide. All right, so now I'm going to hand it off to Dr. Morrow. Dr. Morrow is a critical care cardiologist at Brigham and Women's Hospital. He's also a co-chair of the steering committee for the AHA's Cardiogenic Shock Registry Initiative. So I'm going to go ahead and hand it over to him to take it from here.
Thanks so much, Shayna. And thank you all for joining us for this now fourth installment of the AHA Cardiogenic Shock Registry Grand Rounds that we have on a quarterly basis. We are very excited today to be talking about cardiogenic shock systems of care and to be supported by an outstanding faculty. I'll say that I always say that cardiogenic shock is a team sport when we're thinking even within the microcosm of our hospital. And I think it's also true when we think about the system of care that you have to engage in a city, in a region, for this high acuity, high severity, high morbidity, and high mortality condition. And our outline you see here, we're gonna, Dr. Tim Henry, I'll introduce in just a second, will walk us through considerations about the importance of and how we approach cardiogenic shock systems of care. Then we'll hear a case that relates to that and then have time for Q&A at the end as well. So first I want to introduce Dr. Henry, who is the Carl and Edith Linder Family Distinguished Chair in Clinical Research at the Christ Hospital and the medical director of their research center. And there is really no one who is more experienced in developing and implementing systems of care. He is an expert. He has done this in ST elevation myocardial infarction, and I think is now eager to take on this new challenge in cardiogenic shock. And I think we all are looking forward to hearing from him. So Tim, take it away.
Thanks, David. I'm going to share my screen here and make sure everybody can see it. Can everybody see me and hear me?
Perfect.
All three.
Perfect. So first of all, I'm honored to be here today. This is really a special opportunity, and I'm a strong supporter of the AHA Cardiogenic Shock Registry. I think it's an important step forward in how we make care better for cardiogenic shock. And I did this a little bit different today, and so this will be a new one. So hopefully everyone enjoys this. Let's see, going forward. Okay, hold on. I gotta get my, I'm not getting, there it goes. So I have no disclosures, and that went quick, but for this, it's really about systems of care. But I want to start really and talk this concept of systems of care is really a little personal for me. If you look on the left of the screen, that's with John F. Kennedy, that's my grandfather. And my grandfather died in the 1970s of a myocardial infarction in North Dakota, and really wouldn't happen if we had good systems that we have today. And on the right side is my father, who died of a out-of-hospital cardiac arrest about 5 years ago. And really the same thing fits, is that they both died in North Dakota, and in a situation where if we had better systems of care, maybe that wouldn't be necessary. So I've been focused on systems of care for a long time. For today, I'm going to talk a little bit about shock prevalence and outcome, the importance of the SCAI shock classification, the interaction of cardiogenic shock and cardiac arrest, systems of care, and then shock centers and teams and future directions. So hopefully this will be good. So important first point is this is data from our invasive management of acute myocardial infarction complicated by cardiogenic shock, which was in circulation a few years ago. And the point was there was a point where cardiogenic shock was dropping, but now it's actually been increasing over the last 20 years. And the mortality, depending on how you look at it and how you count cardiogenic shock, is either very stable or possibly even increasing, which is shown a paper from CAP PCI registry. Regardless, I think it's a little bit how you count, but all of us would say we haven't made significant progress since the shock trial. And why? So if you look at it, this is a paper we published a couple years ago in cardiogenic shock. So the shock trial showed that revascularization improves outcomes. Well, after that, now that last year we've had a few larger trials with ECMO and with dangerous shock. But at this time, only 15 trials over 20 years, and only 4 had more than 80 patients. And now we're up to only 7 over 80 patients. More importantly, when you look at the clinical trials that we used, if you look in orange, those were not even taken account of. So for example, lactate, half of the patients, Swan-Ganz catheter, half of the patients, the GCS score on admission, no, not a single trial reported it. So not only did we have not very many trials, but enrollment was slow. Most of the trials finished before enrollment. And even when we did a trial, we didn't keep track of really important variables. So then we're left with this. This is the trials. And basically, since the shock trial, we've made almost no progress, except the fact that Levophed is better than dopamine. And really, until the dangerous shock trial, which we're not going to spend a lot of time on today, had really not made any progress. So why? And we're going to talk a little bit about that and how can we make progress improving outcomes for cardiogenic shock. Well, I think the SCAI shock classification is a really important step forward. You know, this bothered me a lot like 10 or 15 years ago, because if you were in NCDR or you were Medicare, any place, if you came in and you had a wedge pressure of 95, a blood pressure of 95 and a wedge of 20, that was cardiogenic shock. But if you came to the cath lab on a Lucas device getting CPR with a blood pressure of 40 on 4 pressors, that was cardiogenic shock. Those are obviously not the same people, and I think that impacted the clinical trials, as I'm going to show you. So what we needed was a language where we are talking apples to apples, and this is an example of this. These all 3 are car crashes. But I would argue that they're very different car crashes and the impact are very different. And so that's the same concept. And an example was the IMPRESS trial. So the IMPRESS trial, 90% of the patients had a cardiac arrest. The average lactate was 7 to 8. The pH was 7.1 to 7.2. And if you look at the IBA shock, the balloon pump shock 2 trial, the lactate was over 2, pulmonary congestion, patients did not have a cardiac arrest. Well, those are dramatically different studies. And so I think what was important, we put together with SCAI, the SCAI shock classification in 2019, and this was the original one, and the point was to be simple. So A is at risk, B is beginning, and this is kind of hypoperfusion or hypotension without hyperperfusion. C is classic shock, D is deteriorating, and then E is extremis, that patient on the Lucas device or having a cardiac arrest. The other thing we put in was a modifier for cardiogenic shock with the presence of cardiac arrest, and we're going to come back to that. Very shortly after that, there was a paper published in JACC with Mayo Clinic data that showed indeed the Sky Shock classification was very helpful in terms of mortality. If you can look at A through E, significant increased mortality both in the intensive care unit and in hospital mortality. Subsequent to that, there was like 15 different studies, both prospective and retrospective, most are retrospective, but both, and in different settings that showed that the SKYS classification was extremely predictive and simple to use. And so then what we did is we did a follow-up paper where we incorporated the data from all these prospective studies into the classification. And if you can see this is a compilation of data that shows with acute coronary syndromes or AMI shock and with heart failure shock, the Sky Shock classification is very predictive for both. And if you look, a really important part of the second paper was that we talked about not only the SKY classification, but other risk modifiers. So cardiac arrest is a risk modifier, but also age and stage renal disease. And then also the phenotype and etiology of shock matters. So whether it's left-sided and right-sided, et cetera, makes a difference. So the important point was in the second manuscript was to try to outline key factors, and one of which is the risks. The second is a really important part, and when you're talking about shock and putting people in clinical trials, it's important to think that there's patients who are on a recovery pathway and there's patients that are on a deterioration pathway. And as we get to shock teams and having your shock algorithm, it's important that in particular the deterioration, recognizing deterioration and implementing your algorithm or your protocol to adapt to the deterioration is a really important thing. So this is the new Sky Shock classification. Two things important. You'll see within each of the stages, there's some gradations that tells you that the basis of other risk factors like age and end-stage renal disease do impact the stage. But then the modifier with acute cardiac arrest, one of the big things we did was change this to say it's cardiac arrest with unknown neurologic recovery. So if you have a cardiac arrest and you have one shock, that's really the same as if you didn't have an arrest at all. So this is the new Sky Shock classification. I think it's super helpful for both registries, for your own data, and for clinical trials as we randomize people in clinical trials. And we're going to talk. Another key point is this issue about cardiac arrest and cardiogenic shock interaction. So this is a paper that came from our own STEMI network, and it showed if you have neither, your in-hospital mortality is less than 2%. If you have just cardiac arrest, in hospital is 20%, just cardiogenic shock, it's 26%, but if you have both, it's 45%. And to the same point, the paper that we published in JACC right after the Sky Shock classification very clearly showed in the Mayo Clinic data as well that the presence of cardiac arrest compounds the mortality with cardiogenic shock, and you can see at every stage. If you have both, it's significantly higher mortality than you have cardiac or genic shock alone. Why is this important? And certainly it should be self-evident, because if you have a cardiac arrest and unknown neurologic recovery, even if you give a pump, even if you improve the person's function, we don't know if their brain will recover. And so this is a really important factor that when you do clinical trials to understand how many people had cardiac arrest and what was their initial neurologic care. To that point, the danger shock trial, which we'll come back to, excluded patients with out-of-hospital cardiac arrest and unknown neurologic recovery. There were other exclusions as well. Now, what's the consequence of that? That turns out that excludes about half of the patients with cardiogenic shock. So the danger shock trial took 10 years to recruit, which is longer, and things changed over time. But what it ended up with is a more homogeneous patient population to really test the hypothesis. Does a pump for the heart work. And we're going to come back. All right, the next thing I'm going to switch in now and is talk a little bit about systems of care. So this I feel passionate about, and I love this quote by Bill Gates. Humanity's greatest advances are not in discoveries, but how those discoveries are applied. And this is true today for all of you out there, and as we do. First, we had great data that showed initially lytics worked, and then primary PCI was better than lytic, and then primary PCI was better than lytic, even if transferred for primary PCI. We knew that. But how do we put it in place? So when you get a system of care, it's important to know there's three things. There's pre-hospital evaluation, there's triage, 2 PCI centers or shock centers, and there's transfer. And a really good system of care requires all three to be in place. Problem still throughout the United States is only 50% of patients use EMS. It's higher for cardiogenic shock, but with MI, it's still only 50%. And still, across much of America, we don't have pre-hospital EKGs. Now, with STEMI, this has done a really done job. Number one, we've increased the number of people getting primary PCI. It's now about 90%. At the same time, we've decreased mortality, as you see in red. And I'm going to come back to show you that. There's always this discussion about, are we decreasing mortality? And I would argue that we are for sure. Also in the United States, the number of STEMIs is decreasing, and probably because of primary and secondary prevention. But throughout the world, many parts of the world, the actual number of STEMIs is increasing. We developed in 2002 a system of care that involved transfers from up to, at the end, 35 different hospitals. And our goal was standardized care, improve outcomes, have a research network of community and rural hospitals, allowed you to implement data and put in quality improvement programs so that you could change it. And this is the same principle as a shock program. Now, what we did is the key parts of the component, the diagnosis made by the emergency room physician, even better, the paramedic, single phone call, the initial data. The important part of the data is we included everyone. And we were doing 50 to 60 patients at a month, so that we were doing over 600 patients a year at one STEMI center. And this is an example of how it worked. And so there was an inner zone, there was the PCI center, there was a 60-mile zone, and then it was out to 210. And the goal was to have a simple protocol, the protocol for zone 1. We had a protocol for zone 2, but the goal was keep it simple, do it fast, and reduce variability. Now, we follow that up, and we now have what's called the Midwest STEMI Consortium, where we have data from 20,000 consecutive STEMI activations from Minneapolis Heart, Christ Hospital, Prairie Cardiovascular, and Iowa Heart. And I think there's super important principles that you learn from that. So what have we learned? You learned you can do it fast, you can save lives, you can expand the benefits of PCI, you can do it accurately, you can decrease the eligible when untreated, and you improve outcome in cardiogenic shock, which I'll show you. You improve outcome in elderly patients, and you improve outcomes beyond mortality. This is an example. The very first year we put this in place, the in-hospital mortality at 1 year was 4%. And prior to doing this, in the state of Minnesota, the 6-month mortality overall was 13.9%. So we cut mortality in the state of Minnesota by having a STEMI system more than 50% in less than 2 years. And that was true all over the world when you have a do it. This is an example of this for, if you look, this is when we had 3,500 patients, but look in the upper right-hand corner. If you came to the hospital without cardiogenic shock and out cardiac arrest, and you were under 70 years old, only 4 out of 2,000 patients died. Amazing. And if you had cardiogenic shock and you're over 80, still your mortality was only 45.7%. And so clearly it made a difference, and we expanded it quickly, not only for STEMI, but out of hospital cardiac arrest and cardiogenic shock, so that we transferred patients from all these sites with cardiogenic shock to the PCI center. These are the other things that we showed by having a system care that works. The need for ICD at 1 year was less than 3%, recurrent infarction was less than 3%, recurrent admission was less than 8%, and that was only 50% of that was elective. Need for heart failure under 2%, and we improved the time from chest pain to hospital presentation. So there are huge tangible benefits of having standardized systems of care that's STEMI that translate to cardiogenic shock and cardiac arrest. What are the key components? Have a standardized protocol, individualized transfer agreement, so you don't make it up at 2 o'clock in the morning. You have a system in place, single phone call to empower the emergency department, even better, the power the paramedics, and then extensive training, and importantly, feedback and quality assurance, because when you work with non-PCI centers in rural America, there's lots of turnover. There's also lots of turnover at the PCI center. Now then, a really important principle of the STEMI system, if it works, was expand it. Out-of-hospital cardiac arrest, cardiogenic shock, aortic dissection, critical limb ischemia, non-STEMI, stroke, PE. If we were doing this well in America, we would have standardized systems for all of these acute cardiovascular emergencies. Now, does this work and does it decrease mortality? This is a really important paper that was just published in 2023 in JACC from Denmark. And it showed that over time, if you look at from 2003 to 2016, there was an ongoing decrease in mortality during that time period. And that's because better pre-hospital triage, shorter day, statins, change in antithrombotic treatment, drug-eluting stents, radial access. So it's not just door to balloon. It's just not just time to treatment, but it's having a standardized protocol that incorporates all of these. And why am I spending time on this? Because I think this is critically important as we do this for shock. But is this really happening in the United States? Well, another really important study that came from the AHA registry was we published in JAMA 2 years ago that showed that if you're in a non-PCI center, only 17% of patients are actually being treated in 120 minutes. Only 17% in the United States. And did that correlate? Yes, the adjusted mortality was significantly higher for patients who didn't meet the time goals, all of the time goals. So I would argue, even though that we know it's true, we're doing it in selected places around the United States, but we're not doing it well in the United States. And we need to do better by having better systems of care. So hopefully that's a challenge for all of you out there now, because we can all make our own systems better. So I think it's time we wrote this paper actually in 2006, I think, or actually it was later than that, but that time has come to have a national system, and we don't. Unfortunately, it's very regionalized and very individuals. So now let's switch into and spend the rest of the time on shock centers. So really nice paper that was in circulation for AHA scientific statement about contemporary management of shock. When you look at, it's really important to have shock centers, and the shock centers have shock teams that develop standardized shock algorithms for your hospital. The detail of the algorithm is probably not important that you have it. So I'm a passionate believer that for us to make progress, this is what we need to do. And the shock team needs to involve interventional cardiology, cardiac surgeons, heart failure cardiologists, ICU cardiologists, as well as neurologists, nephrologists, and ethics people, because another important issue is when is futility. So these are critical things. Now, we're doing a lot of work out, and I want to give a pitch here for Mitch, the cardiac safety research curriculum, and David has also been very involved, has been working hard about improving our approach to cardiogenic shock. The 4 key areas we worked on: developing shock networks, having standardized approach for a standardized language that we use for cardiogenic shock research, doing informed consent, which has been successful, and paper was just written that shows how to do community consent, and then how to do clinical trials. Now, another really important part of this is advocacy, and I'm going to show you Georgia in a second, but advocacy on a state level should include how do you incorporate pre-hospital care, care at the local hospital, and then care at the shock referral center. And I'm going to spend time in a minute talking about places where I think it's worked well. This is actually the Georgia State bill that developed level 1, level 2, and level 3 STEMI centers, but it would also be translate to cardiogenic shock and cardiac arrest. And you can see the requirements. So that was now official Georgia law, which I think it was very well done, spearheaded by a lot of SCI and ACC people in particular, to put a legislation in place in Georgia that hopefully will be followed in other states. So I'm going to finish up now in the last 5 minutes with where I think future directions. So this is actually data that came from Alex Truesdale at Innova, and there's been a number of different sites around the country, Ottawa, Utah, Innova, and then the cardiogenic shock registry that have shown by having standardized protocols in place with shock teams that you can improve outcomes. And what are the common themes? Having a shock team, treatment protocols that are standardized, hemodynamic ions, so use a right heart cath, early consideration of MCS, which is a little more controversial. We're not going to spend a lot of time today, CICU care, and that will result in improved outcomes, and it's been shown over. I'm going to give you a couple specific examples. So this is actually from Henry Ford, and Henry Ford, again, has worked very hard in level 1, level 2, and level 3, very comparable to what they had in Georgia. This is their standardized algorithm that includes a fellow, includes whether there's futility, includes whether they are deteriorating, and if they're deteriorating, they'll be transferred to the shock center. By the way, we showed early on in Minnesota that you're able to transfer patients in cardiogenic shock and cardiac arrest safely to a tertiary center. This is actually the network. It's a little hard to see, but you can see on the left side is patients that are in network or out. Gray is in network, blue is Henry Ford itself, and the red is out of network. You can see the majority of the patients transferred are actually out of network. And then on the right, you can see green is survival and they're not. And what they've shown at Henry Ford is really excellent survival by having an extensive shock network throughout Michigan, really though. The other one that I want to spend a few minutes on is Inova. And not that we want to go through all this, but the point is they have this is the cardiogenic shock activation. And if for your shock team in your center, you need to do this for your institution with how to activate this thing. This is the cardiogenic shock team coordination, which is very detailed. This is specific algorithm for heart failure cardiogenic shock and a specific algorithm for AMI cardiogenic shock, which are different, and the people involved are different. So I'm happy, I'm sure we can share these with you. These are published, but the important point is when you have a shock center, this is what you need to do. All right, how did it work in Inova? They started putting this together in 2016. They approved it at the end of 2016 and it went live in 2017. You can see as of end of 2024, they've treated 2,200 patients. And this is the mortality. You can see the number of patients each year increased from 142 in 2017 to the last 4 years, 350 to 400 patients that they treat, which is a very huge volume. And you'll also note that their survival improved over time. And they have a very well done registry that looks at this in great detail. So another way, and this as thanks to Alex Truesdale, By looking at this, what the expected cardiogenic shock mortality was compared to what their actual mortality was, they feel like they've saved an additional 600 lives. This is what I think is possible when we have really well done shock centers. So what are the future directions? Beyond shock centers, we've really learned from registries. So one is the National Cardiogenic Shock Initiative. And if you look at this, this is compared to the over, you can see by having standardized algorithms in 80 centers around the United States, overall, their all-comer mortality has improved. I'm going to show you a little more detail about that in the better. If you just look at just Sky Shock C and D, it's 77%. Other principles they've learned that AMI shock, you do worse if you have more pressors. Pressors are bad for AMI shock. You also learn that early hemodynamic management with a right heart catheterization saves life, and early use of MCS is likely to improve outcomes. This is the outcomes that they have, and again, done by whether you're stage C or D or whether you're stage E, because they're very different patients. They also showed that your survival by both your admission lactate and your lactate clearance makes a difference. So this is overall summary. What's the key part that the registry showed us? It starts with optimal PCI of the culprit vessel, avoid escalating doses of vasoactive substance, have a strong hub and spoke model with a standardized protocol and algorithms, and you can make really, I think, improve your outcome. This is actually another example from the cardiogenic shock working group that really shows the same thing. So those two registries, I think, have made a big difference, and I think the American Heart Association registry is also poised to help us make significant insights into what's happening in the United States and how we can make it better. And then the last point I'll make is once you have shock teams and once you have good registry, it allows us to do clinical trials. And all of you, I think, are familiar with the Danger shock trial. And it's not the point of today, but what they showed is eliminating cardiac arrest and using an Impella, you are able to actually decrease the overall mortality. Now, we're not done yet because the downside was it was some expense. There was increased bleeding, increased limb ischemia, increased renal replacement, and stroke. So we need better management, but I think by having clinical trials, you're able to actually make those insights. So routine use of an Impella on top of standardized care did reduce death, but it's associated with adverse outcomes. And I think this, it sets the stage for us to move forward. So I'm going to end with this. This is another, I think, nice paper we had, invasive management of AMI shock in circulation, as AHA sponsored statement, and showed that I don't want to get into MCS today because the important point was to talk about shock systems, but it probably depends on what Sky shock stage you are. But further clinical trials will really help do that. So we're going to end with this. Sky shock scale makes a difference. We need to develop standardized algorithms that take that into account. And then I want to thank you and leave some time for for questions. But I want to thank all the special people around the United States who have worked on systems of care, starting with STEMI, but also with out-of-hospital cardiac arrest and cardiogenic shock. And in this talk particular, I want to really give a lot of credit to two people, Baba Basir, who's at Henry Ford, and Alex Truesdale, who's been in Innova, two really talented young interventional cardiologists that I think have made a huge difference in cardiogenic shock and with shock teams. So finally, this says, oh Lord, here come circumstances beyond our control. I don't think that's true. I think we can make a difference. And my mom's favorite baseball player, Yogi Berra, said, you got to be very careful if you don't know where you're going because you might not get there. So think about that for a minute. It's really true. All right, David, thank you very much.
No, bravo. Thank you, Tim. That was absolutely fantastic. I think we will take a few minutes just for any immediate questions from the audience. We'll come back and have a few at the end. Maybe I'll just start things off and say that, you put it all together in a way that makes it seem easy peasy, right? What are the challenges that you learn from really creating STEMI networks that we need to think about for cardiogenic shock?
So great question, because there will be challenges. But I'll also tell you that no challenge is too big, because the benefits are huge. And I think what you need to do is, first of all, you need to have a passionate person that's interested, STEMI and cardiogenic shock. Number two, I think it's really important to have a STEMI coordinator. That can be a different person, paramedic, a nurse, but to have a coordinator. And that's also true with shock. Even more important with shock, you need a shock team. And that team at your institution needs to meet at 2 o'clock in the afternoon, not at 2 o'clock in the morning, hammer out the details. The good news now is there's 10 places around the country, and I showed you two, that have well-developed algorithms and things. Look at them, use them. Their people will be happy to share it with you, and then adapt it to your system and your region. And everyone won't have, like, Inova and Henry Ford both have 30 plus referral centers. Everyone won't have that. You might just have one or two. You might have 5 or 10, but you know your region. So get a shock team, get people who are motivated and coordinated with your STEMI system, and hopefully your cardiac arrest system as well, and plan out what your specific protocols are for your institution. Then two other important things: keep track of your data, be in a registry. And that's also easy now, because there's several registries out of there. So you can keep track of your data by being in the AHA registry. And then three, make a commitment to be in well-designed clinical trials.
Yeah, no, that all resonates with me immensely. I think having a champion, having the data at your fingertips so you can enact continuous quality improvement is really key. And I'll say, just to build on your point, that we certainly have worked on designing the registry and the reporting instruments in a way that you can look at your own dashboard, you can see exactly what you're doing and how you're doing over time, so that we really want to make that data accessible to everyone that's participating, so they can also benchmark themselves against the overall registry and see, well, am I using much more or much less MCS in this situation? And at least as we generate more data, it will help people calibrate a little bit.
Another point I'll add, you need institutional support. And you can make a strong case for the institutional support. So most of the centers that end up being the tertiary centers have LVAD programs or transplant programs, or both. And I think that's an important part of cardiogenic shock. You can't just save a person's life, you have to have an end game. And so from an institutional standpoint, they should be strongly supportive of developing a well-done network, because it helps their whole system and it helps the patients in the region.
Yeah, no, I think that's an incredibly important point. So Tim, we're going to have you hold on for some more questions at the end. We do have a question in the chat that we'll bring back to you at the end as well. Next, I think Dr. Hagenhat will walk us through. She's a cardiologist at Sutter Health Mills in Peninsula Medical Center, and is going to walk us through a great case that I think will underscore many of the points you made, and then we'll come back again and have another conversation. So Layla, the floor is all yours.
Thanks so much. And thank you, Dr. Morrow, for the invitation to be able to share this case with the audience today. I'm really honored to be able to share this case. Like was mentioned, my name is Layla Hagigat. I'm a cardiologist and a structural imager within the Sutter Health System. So this is a large healthcare organization in Northern California. And specifically, I'm at Mills-Peninsula Medical Center, which is a 300-bed tertiary hospital about 20 minutes south of San Francisco. I have no disclosures. The objective of this brief presentation is to present a real case of cardiogenic shock from Mills-Peninsula that allows us to examine how optimal systems of care, as outlined by Dr. Henry so nicely, can best serve patients and their treatment team. So our case today is that of a 28-year-old man with no drug use history who was brought in by ambulance with acute chest pain and shortness of breath. His vitals were notable for a blood pressure of 100/54. He was normothermic, heart rate was 80. He was breathing fast at 26 breaths per minute, setting 92%. On exam, he was pale and diaphoretic, had diffuse rhonchi, an elevated JVP, and cool extremities. And his labs were notable for an elevated lactate of 5.2, an elevated creatinine of 1.4, and a normal high-sensitivity troponin. This was his presenting EKG, so notable for an accelerated ventricular rhythm with diffuse ST elevations, and this was concerning for an acute STEMI. So in the ED, a STEMI code was activated. Now, while awaiting being taken to the cath lab, several things happened for this patient in the ED. One was he had a bedside POCUS. This showed a severely reduced LVEF with apical akinesis. And then he developed progressive respiratory failure, presumably from pulmonary edema, requiring intubation in the ED. And then shortly after intubation, within minutes, he went into VF arrest. It required 2 rounds of CPR with shocks to attain ROSC. And it was then at this point, now 45 minutes after the cath lab was initially activated, that he was actually taken for an invasive look. And so based on his initial presentation and what his labs looked like, there was enough concern for cardiogenic shock that the first thing done in the cath lab for him was placement of a microaxial flow pump. And then this is what his coronary angiogram looked like. As you can see, there was a 100% occlusion of a large ramus artery. And given the fact that he's quite young and the fact that there weren't luminal irregularities even throughout the rest of the vasculature seen, it was felt that the cause of this event was most likely cardioembolic. And so he underwent aspiration thrombectomy and balloon angioplasty. And the video you're seeing here is actually post-PCI. And you can see that despite these interventions, at best, he had TIMI-1 residual flow. And then he underwent a SWAN placement. So his numbers are as listed here, consistent with cardiogenic shock. So at P8 with dobutamine of 5, his output was 2.2 with an index of 1.1. His SVR was quite elevated at 3,500. PAPI was 1.8, and his CVP over wedge pressure was 0.45, overall consistent with a primary LV failure presentation. So after the cath lab, then he quickly had a return of sinus rhythm. His lactate cleared pretty quickly within a couple of hours. He was started on DAP therapy and a heparin drip, and he obtained a formal ultrasound of his heart. This showed that the EF was in fact low as 20%, and a bubble study was positive, suggestive of a PFO. He also had a duplex ultrasound showing thrombus in the popliteal and perineal veins, and so this confirmed the suspicion that he likely had a cardioembolic event, namely the thrombus in his legs likely traveled through a PFO into the coronary arteries, causing his acute STEMI. And then he did relatively well on post-op, hospital day 1, his microaxial flow pump could be weaned. And by day 2, it was actually removed. He was thereafter extubated, and within minutes of extubation in the setting of it being hypertensive and agitated, he actually went back into arrest, this time in PEA arrest. And 5 minutes into resuscitative efforts, because ROSC wasn't able to be obtained, a shock code was activated. So in our hospital, the shock code immediately pages a multidisciplinary group of experts who are on call. So that is, like Dr. Henry outlined, CT surgery on call, the ICU intensivist, the interventionalist, and also an advanced heart failure specialist to try to get together on one page to come up with what's the next best step for the patient. And so the decision was made, just given how complicated his course had been at this point, that this was now his second arrest, and the need for emergent support, to cannulate him to VA ECMO. Now, at our hospital, we are a level 1 CS center, but we don't implant VADs or do transplants. There's a flagship hospital in San Francisco proper that does that. So part of the discussion that was had with the shock code team was to cannulate him as a bridge to more advanced therapies. And so he did require a transfer to a higher level of care to consider the advanced therapies. Practically speaking, at our institution, what that involves is the heart failure specialist picking up the phone, calling the cardiac intensivist on call at the flagship hospital, and having the patient accepted, and then the transfer center helps take care of the logistics for the actual transfer. So that was done pretty efficiently. Within hours, he was transferred. And at the flagship hospital, he did well. He was able to, by hospital day 7, auto-wean on his ECMO settings. His EF improved, and he was able to be decannulated on hospital day 7. On hospital day 14, he underwent a PFO closure, and his TEE intraoperatively was notable for, as you can see in the pictures here, both a right atrial and left ventricular thrombus. And then he developed an ischemic right upper extremity, so this prompted an ultrasound to be done, and that showed an occlusive thrombus in his right axillary artery. At this point, he had had a lot of issues with clots, both arterial and venous, and so he got scanned from head to toe with a CT angiogram, and this disclosed even more occlusive thrombi. He had bilateral PEs, thrombi in his bilateral lower extremities, and he required urgent thrombectomy of the right upper and lower extremities. And given how extensively he had been clotting, hematology oncology was consulted, and he underwent a complete hypercoagulable workup, notable for diagnosis of HIT. And so at this point, now 2 weeks into his hospital stay, after several clotting issues, he was then transitioned from a heparin drip to nargatroban drip. And then the next 20 days really was intense rehabilitation. And by hospital day 41, after much rehab, he had full neurologic recovery, was obviously very physically debilitated, but was ultimately able to be discharged to an acute rehab facility on warfarin and a baby aspirin daily. So, I think it's a complex case, but it was ultimately a success. And in thinking about what elements of systems of care made this a success, a couple things come to mind that are worth noting. One is that in the ED, there was the appropriate identification of STEMI and early involvement of cardiology by the emergency team. And then in the cath lab, there was early recognition of cardiogenic shock that helped guide the need for MCS to help support PCI. And then lastly, when he was in the ICU, the early utilization of our multidisciplinary shock code team helped to really get everybody together on the same page to bite the bullet and make that decision to cannulate him to ECMO early, and then be able to efficiently transfer him to a higher level of care center for consideration of advanced therapies, although fortunately he never needed them. Thank you.
Layla, thank you. What an absolutely amazing case that you walked us through. Maybe I'll start. I'd love if Dr. Henry has any questions or comments on the case for him to chime in first, and then if not,
Well, so I've probably talked too much, but it's an excellent case, but it really illustrates the issues for cardiogenic shock because there's a wide range of etiologies and and that's why it's really important to have a shock team that involves different people. And even MCS, for instance, the decision to put in the MCS and ability to put it, whether it's ECMO or Impella, is important, but also managing the MCS is important. And number 3, taking the MCS out is important. And typically at most institutions, those are different people. And so there needs to be, and this was obviously very complicated and also involved transfer to another hospital and system. So it really illustrates if you're going to have successful outcomes, how well coordinated this needs to be.
yeah, Layla, I think just as Tim illustrated, all of those points were critical in this patient's path, and maybe talk about in the care that you all provided at your initial hospital within your system was absolutely amazing as well. What are the issues that you see as a referring center into your central hospital What are the things that you encountered that systems can learn from and do better?
Yeah, I think the most common thing, this is a positive case, but certainly there are also outcomes that are much sadder. And one thing in this case that I think was well illustrated and that we did well was early diagnosis, early management, and early activation of the shock team. I think sometimes patients stay in the hospital here and they're transferred a little too late, really for consideration of VAD and transplant. And so I think having the early activation of the shock code team to help facilitate that transfer is tremendously important. And I think things were very smooth from the ED to the cath lab to the ICU. And by hospital day 2, this guy was transferred to a higher level of care. Whereas Dr. Henry mentions, closer monitoring for MCS can be performed. So I think early identification and an escalation of care when appropriate is super important.
Dr. Krukov, I'm going to hand things over to you, and there are a few questions that I have in the chat that I'll chime in with once you're done starting here.
Yeah, thanks, David, and really, Tim and Leila, just it's been another phenomenal grand rounds. Leila, just one question, because so many of the people who I think I see logged in are really at the ground level in making these kinds of decisions. I wonder if we could just put a magnifying glass on a small step, but one that I think the system approach probably influenced. When the patient had had trouble after the Impella had been removed, the transition to ECMO rather than putting an Impella back. Can you highlight that discussion in some ways? Because again, this is not about right and wrong, but that's exactly the kind of moment of you've removed one technology that was working, you have another technology that could be considered an escalation versus equivalent. So can you just share with us a little bit, what was that discussion? Or was it more who was around and technically could get it done faster? What were the discussion points?
Yeah, it's a good question. Thank you for asking. I think several things went into that calculus. One is this is, as we alluded to, like a young gentleman, and there is, I think, a subconscious effort to do everything possible and really maximize support for somebody who was otherwise walkie-talkie and perfectly healthy. He had been on Impella support initially, and I don't think he failed Impella. He appropriately was able to be weaned, but there was that consideration that he had been on an Impella before, so maybe an alternate form of support and therapy would help him. And certainly the decision to transfer was also part of that calculus, is what can we give him to maximize support to ensure that the transfer is done as smoothly as possible. I think those were 3 key elements in the decision making. And also, I mean, to your point, who was available, this did happen in the morning, and so the interventionalist was available very readily to cannulate to ECMO. It's an interesting thought experiment to say, if this happened in the middle of the night, would things be different? I mean, the interventionalist would have come in either case, but I do think there is an element of when it is in the daytime and everybody's around, cannulating to ECMO, should there be complications, is maybe an easier decision to make.
Tim, I'm going to bundle 2 excellent audience questions for you. One was, what are the best ways to educate referring providers on how to recognize cardiogenic shock, since that's such an important early point, as Leila pointed out? And then what do you do in terms of the review of cases to learn from those among the whole group?
So this is both super important questions. One is relationship with the referral hospitals. Let's talk about this. Again, this varies tremendously where your region was. And having been in Minneapolis and Los Angeles and Cincinnati, I'll tell you, it really is, depends on where it is, and the needs of the only way to do it is you have to go there. and you have to meet with people, and you have to have people, each one that you standardize. And when you do that, you can coordinate care really well. Second, you need to provide feedback to them. So the patients that are transferred to you, we had monthly and quarterly uh, information about how patients had done, both STEMI, cardiac arrest, and cardiogenic shock. And I think that was really critically important in terms of the feedback and continuing better. 3, you need to listen in terms of at each one of these levels, people are going to have ideas of how to do it better. And Mitch's point, I will also say about the MCS, what your expertise is. Your surgeons and your interventional cardiologists may have different views of this, and you just have to coordinate that together. And especially if you have an LVAD program and a transplant program, incorporate that with the and come to agreement at 2 o'clock in the afternoon rather than arguing about it at 2 o'clock at night. Is have a plan.
Jim, there's also another question. We have 1 minute left, so we'll aim for a short answer. About transportation, you must have encountered this in STEMI. How do you navigate the transportation issues, particularly from rural areas that may be feeding into these networks?
Again, everything's different. In Minneapolis, we had everyone said you must have a lot of helicopters in Minneapolis. We didn't. There was no helicopters in Minneapolis. They were regionally placed. And Minnesota is such that helicopters are good. If you live in a mountainous region or a region with lakes that has fog, helicopters might not be as easy. And when you may have, in Cincinnati, we have one hospital has their own ambulance. The patient's in the ambulance and coming before they even call us. Whereas other places you have to arrange. So all of that can be very complex, and you just have to know what resources are available and design the system fit for you.
Yeah, maybe I'm going to synthesize that and then hand it over to Mitch if he wants to close with anything additional. It's just that I think you pointed out that you need champions, you need data, and you need to create the right fit for your own environment. And that involves listening to everyone in that whole process of care from the beginning to the end. Mitch, I'll hand over to you.
Yeah, David, I couldn't synthesize it any better. And so I'll just say thanks so much to Dr. Henry and Dr. Hegegat for a great sort of substance for this whole program, to Shana Costello and the AHA team who do the amazing part of expanding the registry and running this as well, and to my incomparable partner in crime, Dave Morrow, for creating the level of where clinical experience meets academic expertise. So thanks to everyone. I hope that everyone online is already activated in the AHA shock registry, but if you're not, on your screen are ways to make contact with what I'll call Shana's Army and come on board. As Tim and David have both summarized, it's only as we work together that we're really going to be able to make the kinds of advances and reach the patients who need help because they suffer from cardiogenic shock. Thanks, everybody. Have a great day.
Thank you all very much.